this morning, the whole theme is about integration of care and what are the enablers for integration of care, what are the enablers in enhancing the quality of care for Londoners. So it's a great privilege to have Emily, Roy and Susan. Some of you have come even across the pond to come and see us. So, from Harvard. So thank you very much for being here. And I just thought maybe you wouldn't mind telling us some of your thoughts about the enablers, but also about the London Commission, and what thoughts you may have on that. So I don't know who wants to start. Susan, you want to start, and then?
Sure. Thank you, and thank you so much for inviting me. I found the morning very, very interesting, and before I make the remarks that I had thought about before I got here, I just want to say that I underscore what everyone on the technology panel said about the importance of having a very strong technology platform. And one thing that they didn't comment on that I think is that also enables, that is critical for something like what you're trying to do here, is that when you have all the data in one place, it also supports much better management of the delivery system and the ability to track the care of populations and of people and to understand how you're actually managing the services you provide. So with that, one of the reflections that I thought about when I read the questions that you posed in the materials we got about the enablers and the barriers, and this is I'm from Boston and run a primary care innovation center at Mass General and for our health system. And I'm also reflecting just my own observations from afar of the National Health Service over many years. And I think one of the critical things that you have to consider is the role of leadership, and having strong leadership that has constancy of purpose and a vision for what you want to see happen with the care of the people who live in London. And from my perspective, I see a lot of turnover, and I see it in our own country, but I see it here as well. And I think the kinds of changes that you all are aiming for are very, very difficult to implement and sustain if people don't know that there is a strong vision and that the leaders aren't going to go away. Because everyone underneath that leadership level is just going to wait till the new person shows up, and they're going to keep their heads down and know that they will outlast everyone. And so I think that that is a really critical thing that I wanted to mention. And I think that one of the things that I am very excited about and am seeing have tremendous impact on a lot of the same issues that you all are struggling with is creating a very, very strong foundation of primary care. But not just talking about primary care as we used to talk about it, but we now have a whole system in the U.S. to recognize primary care practices as medical homes. And medical homes have a very specific set of criteria that focus on access, population health, self-management, process improvement, referral tracking, lab tracking. It's everything that you would want to see and what I think of as the definition of high-quality primary care. And the recognition process actually is a review of whether practices actually do these things or not. And when they do, they often get higher forms of payment, global payments. They get other kinds of support. And we're seeing, I think, really important impacts on reducing readmission rates, reducing inappropriate ED utilization, improving the quality of decision making that affects inappropriate use of care, and all the sort of the holy grail of quality that we're all looking for. But it wouldn't happen if there weren't these standards that are very clear and concrete, and recognition programs where you actually have to document how you're doing things, and including creating very strong teams in the primary care practices where it's recognized that everything doesn't fall to the physician to do. And the other part of this that I think is really important is we're also seeing really significant improvements in the quality of work life for the clinicians and the care team. So people that were formerly leaving primary care are staying, and they're anxious to recruit others into it. And we're also seeing it improve the patient's experience of care. So I think that that's something that I would really encourage you to look at. But it's not just nice words about this is a good thing to do. There are real teeth behind how it's implemented, how it's recognized, and how it's audited. I also think that it's no surprise to any of you, I think, if you know the work I've been involved in, that I think that we have to do a much better job of engaging the public in the improvement work and in the actual redesign of care and redesign of the system. We talked a little bit about that this morning when you were talking about what's happening with all the property. But I think that it's very critical in terms of how you plan to redesign your care system. And again, in my own work, what we find is that that does two very important things. Number one, we get it right. We don't waste our time on things that don't matter. When you put a group of people like us together, we typically come up with the most expensive, difficult to implement, and wrong solutions one could imagine. And when you have patients at the table or family members, depending on the nature of the issue, they tell us exactly what they need, and their expectations are not wildly inappropriate. The other thing that we found in our system is that it really helps us save money. They tell us what we've planned that they don't need and we could get rid of. And I could give you examples from here till the end of the week about things that they've helped us avoid that made our work much easier. I also think that we need to do a much better job, and I think the technology can help with some of this, of providing really useful information sources and decision aids to the population that help them make the right decisions. I think it's a patient safety issue, and I think it also helps improve outcomes. And the final thing that I want to mention is that we also have to do a lot of work around our professional education. We don't train clinicians to know how to work in teams. We don't train them in a lot of these communication skills, and we don't train them at all in process improvement. And all of those things have to come together so that you can actually design the models of care that give people the time to have the conversations they need to have if you're actually going to involve patients in decision making. And I'll stop by saying, you asked us if there are places to visit.
Yep.
I think you should come visit Boston. I think that we have done a really wonderful job around population health management, around taking care of our highest cost patients very effectively and reducing the cost of care. And it's pretty difficult to do this when you are in a city of large academic medical institutions that have made a lot of money on overuse and inappropriate use, and that's really starting to change. And I think we've also done a great job with our technology. You know, I've had access to my own records, including clinical notes that my physicians and my care team write about my care since 1999. So I'm a little nervous when I hear 2015 is the goal, so I will stop.
Thank you. We'll visit Maine when the snow melts, as they say. So,
that could be August, given how it's going.
Thank you. Roy, thank you for being here. You know, you've been around the block. You've won the T-shirt. You know all about the challenges. So I have no doubt you're going to be very frank, and I'm look forward to your thoughts.
Mr. Chairman, thank you. Ladies and gentlemen, good morning. I'm here, I think, probably in my role as the chairman of the People's Inquiry into Healthcare in London. We've just completed 7 hearings. We've had 30 hours of testimony from over 100 witnesses, and we're still working on the transcripts of 100,000 words. We're ploughing through that. You've got all that to come, I fear. We've had 25 additional written submissions, and there's a lot of work. And we aren't due to publish until March. So I am in some difficulty in giving you a definitive view from our inquiry, but I think with the permission of my colleagues on the inquiry, I can take you through some of the things that we found that might help you. And I think there are, of the items you've asked us to consider, items 1 and 2 and 6 are probably the things I can best help you with. What are the barriers in the healthcare system to providing high-quality care? What are the barriers in the healthcare system to providing more integrated care? And finally, does London get the right share of funding to support the health sector? So, I mean, we have, fresh and up-to-date information on that. I think probably the operational squeezes that the London is going through, and indeed the rest of the country, have produced a sort of management climate that seems to us is focused upwards, with patients playing very little part in what is happening. The operational challenges that there are on the hospitals have produced a diagnosis of failing services, where really we found them heroic services, battling against very difficult circumstances, overheating health economies, and the inability to recruit enough staff. I mean, those really, if you look at all the quality failings, it's all about what's happening at the front line. And the key for me has always been you fund the front line properly, protect it fiercely, and make it fun to work there, and your problems disappear. But it isn't any of that that we found, and it's a toxic mix that we've discovered. We've seen and heard from staff who've told us about bullying and suppression of whistleblowing, job losses, and all threatening quality of care. I think it's fair to describe that this is the unanimous view of my panel. We've taken evidence from a spectrum of people from, for example, Sir Robert Naylor, who was very interesting how he handles whistleblowing within his organisation. He also told us that less than 9% of his turnover comes from his local CCG. So what chance has the CCG got to influence what's happening there? He was a fabulous witness. We've had NHS England who've been struggling with reconfigurations. GPs have been good, through to the sacked whistleblower and union activist Charlotte Monroe, who was really very poignant and emotional, really, I thought. We took evidence from the chief economist at the Nuffield Trust, who drove home the point that assuming the nigh-on impossible efficiency gains that the NHS is trying to achieve in the 2010-2015 window, and the forecast after 2015, it is just not doable. We've hit the target halfway through, but that's only by sacking people. In terms of efficiency gains, we just don't see that circle can be effectively squared. And the savings are being taken out of the payroll. I mean, we've heard, and we all know, the difficulty, for example, that Barts is facing. And we've heard that one of their primary solutions seems to be to cut staff. And this is a service industry. You can't cut staff and deliver safe care. On the topic of barriers to integration, the most significant point is really the lack of any non-confrontational democratic framework for genuine engagement between the NHS, local politicians. We've taken evidence from 3 local politicians in London, all of whom have complained that they can't find out what's going on. Now, if an MP can't find out what's going on, who the hell can? So that was really quite surprising, really. There's no workable, doable mechanism for people to engage and find out what's going on at the time of great change. Changes that are being driven by the money, really, and we all accept that, but there's no consensus. The CCGs don't come out really very well. We had one story of a CCG who'd opened one of their meetings to the public. The public asked too many awkward questions, and the CCG adjourned and finished their meeting in the kitchen, away from the public. So they don't come out of it very well. Sir Steve Bullock, who is one of the first elected mayors in Lewisham, was a hugely impressive witness. And I do hope that, Mr. Chairman, you'll find time to listen to him. He was a powerful testimony, but he is very sceptical of being able to work within this system. And you get people like Steve Bullock who could make anything work, but there's only one Steve Bullock. That's the problem. And he had huge difficulty. As an aside, we took evidence from the Lewisham campaigners, and what they told us was little short of a farce in the way that they've been treated. They were deceived, they were threatened, they were lied to. And it was a disgrace, and it casts a terrible shadow over trying to reconfigure services in London. When people look at what happened to Lewisham, they say, well, is that going to happen to us? And the Department of Health was struggling with a dysfunctional piece of legislation. We know that. And, of course, instead of putting up their hands and saying this legislation isn't fit for purpose, we'll change it, they pursued the whole thing into judicial review, spent fortunes, and got nowhere.
Which legislation is this?
Which one?
Which legislation are you talking about?
The
2010 Act.
The TDA, yes.
Yeah.
Well, the legislation, yes, the 2010 Act that's in place that allows, doesn't allow service reconfiguration. So if a trust is in financial trouble, all effectively the liquidators can do is to fix it for that trust. It didn't allow them to take into account the wider health economy. And, of course, the solutions lie in the wider health economy. We all accept that.
Yeah.
But instead of the government saying this is a potty piece of legislation, we'll try again, they pursued it and spent a fortune knowing, and everyone said the judicial review would fail, and it did. And the difficulty with that is not so much that their obduracy, it casts a shadow over other reconfigurations, and there are a lot of them, as you know, going on in London at the moment. And everybody's saying, whoa, look what happened in Lewisham, we're going to get ripped off as well. Sure. So it sours the whole thing, I think. We heard a series of stories about CCGs who are struggling and shambolic, really, badly run, far too small to be effective, and the engagement with the public is poor. London has lost its strategic health authority, and I think the CCGs have failed to engage constructively with their local communities. I think it's fair to say that. And it's the absence of an overarching strategic framework that is the difficulty. I was listening to Paul Corrigan earlier, and I think I think I disagree with Paul Corrigan, which is the first time it's ever happened, but I think I do, because I don't know how many CCGs there are in London. I can't call the number to mind.
32.
Yeah, it's a ridiculously high number, and some of them are just, I don't know what they are. They're like bridge clubs. They're too small, and you can't run a healthcare system like that. We need a balance between the kind of thing that Sam does, which is the intensely local, highly valued kind of a service, but how to fit that into the broader framework where I've already told you. Bob Naylor told us that less than 9% of his turnover comes from his local CCG. They just don't have the influence to change anything. So the provisions of the Care Bill now, Section 118, of course, we are told that that's in place because it's necessary to move quickly to protect services, particularly when they're running out of money in London, and I accept that.
Yeah.
But the damage has been done by not engaging properly with the public. I think there are... shall I just one or two more points? To look on the more positive point, I think we haven't reached our conclusions yet, but I think some of the conclusions we are going to reach are, first of all, that primary care largely is too small. 70% of the estate is either incapable of getting a planning consent to expand or actually physically capable of being expanded to take on more. So I think it's silly to just keep piling more stuff onto GPs and say, you do that. It may be a great idea, but I just think physically they can't do it. I think that the London hospitals are too big. They need to be broken up. We've gone through the bigger is better, but they just can't be run. And the evidence that we've taken is the boards are really very poor. They don't engage with their public, they don't represent their public, they don't even look like their public. So I think there's a structural problem at board level. How to solve the issue about engagement? We quite like the idea of citizens' juries, which have been used by NICE, of course, in the examination of expensive drugs. We think that might be a way to go. The Federation of GP practices, I think GPs and CCGs, they better learn the difference between federation and confederation, because I think if they federate, they're going to end up not wanting to do it. The role of the mayor, what is the role of the mayor in London? I think I disagree with Paul. I think the mayor does have a very important role to play in the strategic planning of healthcare in London. We can't carry on with it. It's like Granny Shaw. We've done a patchwork in London. It's not cohesive. And I think that the long-term conditions where we took evidence from people with long-term are just going to crush primary care. And we need to move to technology-based and just, we've got to move away from the idea that long-term conditions are a job for the GP. They're not. They're a job for somebody, something else, somewhere else. We need to redefine that. And so that's it. We report in March.
Yeah.
And I don't think our report is going to be happy reading for politicians, health staff, or the people of London.
Thank you. Thank you, Roy. Thank you very much for sharing that with us. I know it's mostly confidential, but very grateful. Emily, do you have any thoughts about improving the quality of care or integration?
Indeed, and thank you very much for inviting Carers UK to give evidence today. I want to speak on behalf of the families who are caring for relatives, are the patients, if you like, in the system. We know that those families themselves are also patients themselves within the health system. But also, I suppose, to draw your attention, perhaps if it's not been looked at, to the impact of not integrating care on the wider health economy, on families, and what that means. I think we're absolutely all in favour of a very strong health economy here in London and the rest of England and beyond. If we just look at the statistics of what has happened over the last 10 years, at this given point in time, there are 670,000 family members who are caring for somebody with a long-term health condition or a disability. So that's approximately 1 in 8 of every adult Londoner, which is an enormous number of people, and that's at any given time. A third of those will start caring, a third of those will stop caring in every year. What we found over the last 10 years is there's been an enormous increase in the numbers of families who are caring. So there's been a 16% increase overall, but in older carers, those over 65, has been the largest increase of over 30%. Not only have we seen an increase in the amount that families are doing, we've seen a huge increase as well in the numbers providing over 50 hours care a week. And why this is a matter of concern on several levels is the first is that those who are providing over 50 hours of care a week are also the ones who are twice as likely to be suffering from ill health. If you go lower down the age scale, you find that those who are younger, sort of the 16 to 24, are 3.5 times more likely. And that's because of the sort of the types of caring situations that they have. But the wider impact of that is in the workplace. For example, 1 in 8 people within this room will be caring for another relative. The impact on them tends to impact on their work and their work patterns. So 2 million people have given up work in order to care for their relatives. So when care doesn't work well, this is how it impacts, this is how the health economy impacts beyond that direct patient who's receiving that care to the wider family. And that's precisely where we need to make sure that we look beyond just the person that's in front of you and consider the wider impacts. That, of course, has an enormous impact on business, and particularly London and London's economy. Perhaps, as everybody knows, the economy in London is working, certainly is growing faster than any other part of the country, and employers want to keep their employees, and certainly their talented employees, and the ones that they lose are those 45 to 54, and particularly women. And this has a particular gender implication as well, which is incredibly important, that these are also the people that we're losing from the labour market who will end up on lower incomes. We know that we have downward social mobility as soon as people give up work to care, and then that has an impact again on the health economy. So we've undertaken a very large-scale survey amongst carers, asking them lots of different questions, important questions about healthcare and the delivery of care. And what we find is that families, if you like, soak up some of the inefficiencies in the integration of care. So they are the ones that knit the pharmacist with the GP practice, with the community nurse, if they have that support. They're the ones who call on the out-of-hours service, the ones that drive to A&E, try and work around admissions. If somebody is very severely ill in hospital, they're the ones that visit. They feed the relatives, they help with the discharge, and then they care beyond. So my plea, if anything, is to the health economy to actually look beyond the patient, There is no duty to promote the health and well-being of the family member throughout the health service, even though it relies on their support to the tune of £119 billion a year.
Is that much?
It is. I mean, it's absolutely enormous. So the value of family support basically is the equivalent to the value of the NHS. And where we see good practice is where people understand that the family needs to be brought in as a partner in care, if you like. So where we would most like integration is across several different levels. First is the vertical integration within the many different parts of the health service, and I know you have received a lot of evidence about some of the lumps and the bumps in the system. A look at the tariff system that perhaps holds up things like technology, particularly healthcare technologies, that could be moved into the community. If I were to give you an example of diabetes, for example, the fact that people self-test now, people own that information, understand it, and really manage their healthcare. If we could translate that to several other conditions, for example, to stroke, for example, and get more home testing there, families not having to take their relative to a GP surgery every 2 or 3 weeks can make an enormous amount of difference. Being able to access patient records as well and manage that care makes an enormous amount of difference. We would also, I think within this inquiry, the other incredibly important part of the system is, of course, the social care system. And we are patently aware of where you get starvation in one particular area and the underfunding, and where that impinges then on the health sector. Some very good examples are, we have a fair amount of evidence of where people are caring for their relatives. To give one example of one woman who needed follow-up surgery for bowel cancer, but was unable to do so because her husband with dementia, she couldn't get care services for her husband. So the short-term worry about her husband was preventing her long-term health and her health future. We have evidence that families are not going to screenings, regular health screenings, or looking after their own health needs because they cannot get the care.
These are London-specific examples.
These are yes, these are all London-specific examples. So I want to make a plea as well for healthcare and looking at the integration across the two, where we get excellent integration. As you know, there's strong evidence of where hospital discharge is smoother, it's less traumatic for those individuals involved, and also where social care can prevent those emergency admissions to A&E. And again, what we're doing with our survey, our UK-wide survey, is pulling out the data for you around London to look at some London-specific examples of where we could load different parts of the system and transfer as well across health and social care to improve those journeys throughout the system.
Thank you very much for that. Thank you all for a wonderful, being so open and frank and very rich. Any questions?
A couple of things. In terms of your proposal, what you were describing in Boston, you said you need to get the incentives right. I'm not sure if you used the word incentives, and that the arrangements had teeth. Can you just say a bit more about what did you do? What did you change? Yeah.
Yes. Our system and our partners' health system is the largest health system in the Northeast of the United States. And so we have 275 primary care practices. When we started to develop and try to implement the medical home model, there was terror on the part of the practices, the clinicians. What are we going to do? How are we going to do this? So we decided to put into place incentives that would move them up the learning curve. And we started off with 40% of the physicians and at least a smaller percentage of the clinical office staff had to participate in process improvement courses. And by doing that, they got paid an incentive for meeting that target. Mm-hmm. They had to create care teams that were very well defined with particular people on the care team, a medical assistant, a nurse, sometimes a pharmacist that would support the physician. And those were very well defined. And we had a number of things like that. They had to understand and take action on lists that we would send them of all their high-risk patients. And we have care managers in the practices, and they had to demonstrate how those care managers were taking care and supporting the care teams with the care of the really chronically ill. And there were many things like that, and then a few technology pieces. And for that, they got paid an incentive for each practice, and it wasn't to the physicians, which was different from what we normally do, because this was meant to engage the entire team in the practice. And they got paid an incentive. And so we have moved them up. Every year we add more things. So this year, for example, one of the things that we've added, because we know that in our chronically ill, our sickest patients, about 80% of them have behavioral health or substance abuse issues. So now we're embedding behavioral health resources in the practices, and the first step is screening everyone for substance abuse and depression. And so now they're going to get an incentive for doing that. So all the things that we want them to begin to build in, we're giving them an incentive so that they can actually do these things. We give them support through coaches and time to do it so that they take hold.
Okay, that's fair.
Sure.
Yeah, I've got a question for Emily. I mean, you were describing the role of family carers, and actually, for many people, they are effectively they are the care coordinator. They're doing all the work. What would most help family carers do that job better, and whose responsibility is it to provide that help in a London context?
I think what would really help would be a very strong steer from NHS England, really, around, in the absence of any legislation that really helps primarily. I would say that a very strong strategic steer, as well as the oversight, I think, of the Strategic Health Authority. I think one of the fundamental things, one of the fundamental frustrations is we're brilliant clinicians and medical staff and other care staff, when they listen to the family and take on board, whether these meds, and he has a bad effect, he has a bad reaction to this, and this is what you need to look after. If that's not taken on board as you go through the health system, it's incredibly frustrating when you have all that responsibility and no power, and no respect and no value. Now, I have to say there are many examples of great people within the NHS who do that, but structurally, the system doesn't facilitate that. So, and I think where we have seen bad examples of quality of care, particularly around mid-staffs, for example, the people who were making the complaints were the family, and they weren't listened to. So this is where we really need to change this. We needed a different culture, really, where we appreciate the impact on family and we bring them on board. So as well as solving some of the strategic planning issues and the vertical integration within the NHS, we need to have a better system of identifying people who are caring and giving them the information and advice to do that safely and well. I always think it's very interesting that we spend a long time training our professionals, except we expect a 75-year-old to take her husband home and care for him, with medical input occasionally, but she's the one who's responsible at 4 o'clock in the morning, and she's the one who would be making the call to emergency services if things don't go right.
Thank you. Any other? Yes, Sam.
Yeah. I was just very interested in what you think the time a GP should spend, all of you actually, what time you think a GP on average should spend with a patient every day, and how many patient contacts do you think is a safe number in one day? And I think it'd be quite interesting to see the comparison between the two countries. And then one very specifically to Roy, if I was able to put you in charge of the NHS in London, what would you do in your first week? 3 things. And what would you do in the first year?
Okay. How long should you spend with your patients? Well, as long as you need to.
Average.
Well, yeah, I mean, we talk about the 8 to 10 minute thing now, don't we? And you can divide that into your working day, and you can find out how many people you see in a day. You might see more. I don't know. I always think that's kind of a bit of a false thing. I mean, on the subject of carers, if I just go off piece for a moment, I don't know why if we've got younger family members, why we don't say to them, "We'll pay you." We'll train you, and we'll pay you, because there never will be an army of enough of healthcare assistants to do it. They'll turn up and give you 12.5 minutes and get you can wash your bottom half on a Monday, Wednesday, and Friday, and your top half on a Tuesday, Thursday, and Saturday. There never will be enough time. You just pay the relatives to do it, train them properly, and give them respite, and let them look after their families. Because it's not as everyone looks for silver bullet solutions, but the silver buckshot. It's the aggregation of minor gains. We can do something. Not every family will be able to look after their. I mean, my mum's 94. I look after her. But not everyone can do that. So, where you've got younger family members, you say, right, you got a job? Yeah. How much are you earning? I don't know, 25,000, 30,000 a year, fine. We'll pay you. We'll give you that tax-free, but you've got to go in a course and we'll teach you to do it properly. And then that way you grow in a different kind of caring environment. As far as what would I do? Well, I would vertically integrate care. You won't like the idea of what I'm going to say, Sam, but I would give the money to the big FTs. And I would have population-based, capitation-based budgets in an area. I'd give the money to the hospitals. I'd let them vertically integrate with primary care, buy you out. I would let GPs sell the goodwill in their businesses so we can move some of these GPs on and get them onto a proper salaried basis, so we don't have to keep giving them more incentives to do everything. And I would break that up. I would have the GPs run effectively by the hospitals, and I would have social care run by the hospitals. Because if we're trying, I look at this as a business. If I was running a business and I needed to control the input here, the process there, and the output there, would I want it in 3 different places? It's like going to Marks and Spencer's and saying, I buy a shirt from Marks here, but I can't buy a tie. I've got to go down the road to get the tie, and I've got to go somewhere else for the socks. It's nonsense. So I would vertically integrate the whole shebang, and that kind of takes us back to where I came in when I was the chairman of a district health authority. We didn't do it very well then because we couldn't manage the money with the same acuity and the same as in the days before Excel spreadsheets. So we couldn't do it. So I would vertically integrate care.
Thank you.
Are you all right?
Okay.
Could I just quickly come
yes.
back on Sam's
Yeah.
point, because I do think it's very important, and I think that's about people's capacity to learn and their knowledge. And I know that some of the families that we work with have incredibly complex decisions, and certainly the 7-8 minutes is not enough for that GP to be able to feel that they have done the right thing. I know you can book double appointments, but I'm a firm believer now with the internet, with knowledge, that actually people can build up capacity about their conditions and learn more about self-management. And I'd be keen to encourage that more so that we take a little pressure off GPs, and where people have very good relationships with the GPs and develop good relationships with different nurses in practices, it really works well when families can just touch base. But I think the professionals need to be in charge and need to have a bit more flexibility.
Excuse my ignorance here, but I thought we do pay some carers, do we not?
Yes, through the direct payment system.
No, you pay the. Sorry. But you pay,
that's all right.
Well, you pay the individual, don't you? They get a carer's allowance. It's a £70 a week thing, and there's something else, isn't it?
No, it's that's an income replacement. That's slightly different. But there is a barrier to paying relatives at the moment with a social care payment called direct payment. There are some exceptions, for example, some very severe or complicated conditions, or maybe dementia, or with different ethnic minorities where you can do that. But it doesn't happen very frequently.
So we can start a carers campaign in London, very unique, very specific, very legitimise the role, and maybe give them some professional training. Is that what you're saying?
Absolutely.
Okay.
I think if you were to very, very simply, and they do this in some places actually, certainly Surrey, for example, have opened up some of their professional training courses to family members. Things like manual handling. We have such strong rules for our workers, and we allow families to
just very briefly, Sharon, when I ran the hospital, I did it with our dementia patients. We trained the relatives. We sent them on courses to look after their relatives properly. And as you say, lifting, health and safety, and all that, but and the specifics that are required looking after patients with dementia. So we sent them as as volunteers, and they used to come into the hospital and help as well.
Yeah, and closing. Yeah.
Go ahead. I was going to respond to your question, but
sorry, go ahead. Yeah,
just very quickly, we aim for a panel size per PCP about 1,800 patients, and in terms of our visits, we're really trying to move toward 15 to 20-minute visit lengths, coupled with getting rid of as many of the sort of knee-jerk follow-up appointments that we've traditionally just done, so that you can handle more things virtually and over the phone.
Yeah, thank you.
It was just to make a point, really, and to ask Susan a question, just to pick up on Roy's point about integrating under FTs. We should remind ourselves that London's got an acute shortage of FTs. It's not got a shortage of trusts, but it has got a shortage of FTs, so I'm not entirely...
It doesn't have to... Sorry, if I may just, Chairman, it doesn't have to be an FT. I mean, I think the Trust Development Authority's pursuit of FT status, trying to make the books balance and all the crunching that does to the front line is futile. There is no point in being a foundation trust anymore. The brand is not in any way superior. It's a hospital. Who cares if it's an FT or what it is? It's a hospital.
But I suppose the underlying point, which is what I want to ask Susan about, was the beyond incentives, I guess the organisational development and capability that's available for primary care, so access to training and IT, the kind of things that you would take for granted in big institutions. Is that something that your organisation provides to the 275 practices?
All of our physicians for several years have had to use the same technology platform, the same electronic medical record and all the systems. We don't own all of those 275 practices. Some are affiliated, primarily the community-based ones, and I would say about half of them are owned by the hospital systems that are part of our overall larger system. But we do also provide, we provide most of, if not all of, the process improvement education and a lot of the clinical education, the CME courses and that sort of thing, but we try to dovetail those with innovation courses, but those are provided by the system. But they can go and do whatever they want to do on their own, but we give them a lot of support.
Okay. Well, thank you very, very much. Thank you, Susan, for coming all the way.
Thank you.
Thanks, Roy, for your time. I know how precious that is, and thank you very much, Emily, and this has been very, very useful. And if you have any other thoughts you would like to write to me, please do. We'd love to hear more.
We will submit our final report to you.
Wonderful.
In March, I think. Does that timescale suit you?
Perfect.
Right. Thank you very much.
Perfect. Thank you again.